Skin, basal cell, or squamous cell. Basal cell are generally pearly and ulcerated. Nodular is the most common at 60%, followed by superficial at 30% and morpheoform 5 to 10%. Infiltrative basosquamous subtypes are rare and more aggressive. Again, most common is nodular, then superficial, then morpheoform. Infiltrative basosquamous subtypes are rare and more aggressive. Squamous cell, risk factors are UV exposure, fair complexion, and chronic irritation. Basal cell cancers are generally low distant Mets, lymph node positivity, and perineural invasion risk. Squamous cell has slightly higher risk of perineural invasion, 2 to 15%. Well-differentiated squamous cells have very low lymph node positivity at about 1%. Poorly differentiated squames, greater than 3 centimeters, greater than 4 millimeters depth of invasion. Lip lesions and temporal lesions have a higher lymph node risk at 10 to 15%. The highest lymph node risk is conferred by squamous cells from burn scars or osteomyelitic sites, like Marjolin ulcer. The lymph node positivity there is 10 to 30%. Gorlin syndrome is an increased risk of basal cell cancer and medulloblastoma. These patients have a high sensitivity to ionizing radiation. Workup for skin cancer should be H&P with attention to skin and cranial nerve exam. Question about immunosuppression. Signs and symptoms of perineural invasion. You want to do a biopsy and a CT for suspected nodes or bony invasion, an MRI for suspected perineural invasion. You generally reserve radiation for patients age greater than 60 due to issues with late cosmesis. Lymph node Mets are very rare for basal cells, less than 0.1%. Basal cell and squamous cell staging, T1 is less than or equal to 2 centimeters. T2 is 2.1 to 4 centimeters. T3 is greater than 4.1 centimeters or minor bone erosion or perineural invasion that's greater than 0.1 millimeter diameter nerve. T4 is bony invasion or skull base invasion. Again, minor bone erosion is T3. Perineural invasion greater than 0.1 millimeter caliber nerve. T4 is bone invasion and skull base invasion. End staging as per usual, head and neck. The NCCN risk factors influences surgery type. The patients are considered high-risk surgery if any of the following. If they have any area that is a size greater than 2 centimeters, if they have an M area of the cheeks, forehead, scalp, neck, or pretibial regions that are greater than 1 centimeter. So in this image, anything that's black is considered the M area. Again, you can see the cheeks here, the forehead and the scalp, the neck and the pretibial area down here. If you have a lesion that's greater than 1 centimeter in that M area, it's high risk. And then the H mask area of the central face, the eyelids, the periorbital, nose, lips, chin, mandible, pre or post auriculars, you can see here, temple, ear, genitalia, perineum, inner portion of the buttocks, hands, and feet of any size. Other high risk factors for surgery are poorly defined borders, any recurrent tumor, any patient that's immunosuppressed, has a rapidly growing tumor, any tumor that's poorly differentiated or with perineural invasion or lymphovascular invasion. Basal cell or squamous cell surgery followed by adjuvant radiation versus definitive radiation is your treatment approach. Surgery, standard excision for these low risk lesions, 4 to 6 millimeter margin is required. You prefer a Mohs surgery for high risk lesion or standard excision with wider margins. Post-op radiation for positive margins or extensive perineural invasion or large nerve perineural invasion. You could also consider for invasion of bone, cartilage, or skeletal muscle. Definitive radiation can be done if the patient refuses surgery or is not a surgical candidate. Some early stage lesions can be treated topically with 5-FU or imiquimod. If a patient has a squamous cell and there's concern for nodes on exam or imaging, you do an FNA. If the FNA is negative, then you can observe the neck, but if you're really worried about a false negative FNA, consider repeat FNA or do an open lymph node biopsy. If the FNA reveals a positive lymph node, you resect the regional nodes and give postoperative radiation for multiply positive nodes or extracapsular extension upon that lymph node dissection. If the patient is not a surgical candidate, then you perform radiation to the positive nodal basin. If a parotid node is involved, then you do a superficial parotidectomy and an ipsilateral neck dissection. For head and neck cancers with adverse features like deep invasion, high grade, large size, etc., you can consider elective nodal coverage even if the imaging is negative. Consider systemic therapy for intact node positive that aren't resection candidates, or extracapsular extension for squamous cell in the head and neck region. Hedgehog inhibitors for metastatic basal cell. Evidence basal cell or squamous cell electrons, but do IMRT of treating nodes. The dose for intact lesions is going to be 60 to 64 gray and 30 to 32 fractions. If they're less than 2 centimeters in size, just remember 60 and 30, and then, bump it up by 2 fractions to get to 64 to 32. 66 and 33 fractions if it's greater than 2 centimeters in size. If the patient wants a shorter course, you have a couple of options. You can do 55 gray and 20, 44 gray and 10. Mnemonic to remember this is double digits for definitive radiation for intact: 66, 33, 55, 20, 44, 10. DDD. Skin surface brachy can be 40 gray and 8 fractions at 5 gray a fraction, or 44 gray and 10 fractions. Each treatment is 2 or 3 times a week. Each brachy dose should be at least 2 days apart. Postoperatively, 60 and 30. If you want a shorter course, you can go back to this, but just drop it from 55 to 50. 50 gray and 20 fractions. So post-op dose, 60 and 30, or 50 and 20. Prolonged regimens are better for cosmesis. In terms of margin, small tumors that are less than 2 centimeters need a 1 to 1.5 centimeter margin. Larger tumors greater than 2 centimeters need a 1.5 to 2 centimeter margin. You can shrink the margins if they're close to a critical structure like the eye, and you can do lead collimation around that critical structure. You prescribe the electrons to the 90% isodose line with a 1 centimeter bolus. For squamous cell cancers with regional nodes, status post dissection and no extracapsular extension, do 50 and 2 gray per fraction. At risk and clinically negative and not dissected, 50 gray and 2 gray per fraction. Status post dissection and ECE, 60 gray, 2 gray per fraction. Clinically positive, no dissection, 66 gray, 2 gray per fraction. For the eye, do lead shield, anesthetic eye drops, pre-treatment with an eye patch, post-treatment due to impaired corneal reflex. For nose, wax bolus over the entire nose to convert it into a box-like contour to improve the dose distribution. For lip, you need a lead shield between the gingiva and the lip, IMRT of treating nodes. Wait 6 to 8 weeks postoperatively if a graft is used. The entire graft should be included in the target volume. Technique and planning. Toxicity include telangiectasias, pigmentation changes, and epilation. Constraints. Mainly local control, generally is 90%. Better for basal cell than squamous cell, will dip slightly for larger lesions. T1 has a 95% local control. T2, 85% local control. T3, 50% local control. If clinically perineural invasion, local control is only 50%. H&P and skin exam every 6 months afterwards is your follow-up.